So I'm just going to kick things off by starting to talk about contract changes for the current year. So there aren't actually a huge amount of changes to the core contract funding this year. It's the last year of the 5-year framework funding that was agreed. And so next year may see some more significant changes. We'll have to wait and see where we go with that. The overall increase in funding this year is aimed to give you just a 2.1% increase in your funding. The global sum funding has increased by 2.5% from £99.70 per weighted patient to £102.28, with the out-of-hours opt-out being increased by the same percentage. The value of the QOF point has increased by 2.8% from £207.56 to £213.43. However, as in previous years, so is the national average list size. So in reality, it's unlikely that QOF income will increase significantly for practices where list size is fairly static. Additional core funding for practices is fairly minimal at only 2.1%, whilst government recommendation is a 3.5% increase in staff salaries, and the predicted CPI inflation is 4.1%. So it's therefore no surprise that the contract has not been accepted nationally. But to date, there hasn't been any suggestion of any changes to this funding, and these contract changes have been enforced from the 1st of April. There's some further funding via PCNs, mainly from R's funding, but with COVID vaccination income tailing off, it's fair to say that it's likely to be a difficult year financially for GP practices this year. QOF funding then, moving on to the QOF funding. Looking at QOF in more detail, I mentioned that the national average list size has increased from 9,374 patients to 9,639. QOF's paid at £213.43 per point achieved. However, this is adjusted for your practice list size compared to national average list size. So if you have a list size that is lower than average of 9,639, your QOF value per QOF point will be affected. Just looking at the next slide then, as an example, if your list size has increased by the average of 2.8%, then you'll see that you would have received an additional you will receive an additional £5.87 per point at the bottom there. The example on the right, however, shows a practice whose list size is static. As you can see, the value per point last year was £177.40. Was 177.14, for that practice, with an average list size of 8,000 patients. This is calculated as 207.56 being the average cost per point, divided by national average list size 9,374, times by this practice's list size of 8,000 patients. For the current year, with a list size still of 8,000 patients, £213.43 divided by national average list size 9,639, multiplied by this practice's list size of 8,000 gives you the same value per point of £177.14. Prevalence is also taken into account, so it isn't quite as straightforward as this example, but it clearly highlights that list size is as important for achieving the points when it comes to QOF and actually getting that money in. Other changes to QOF include the total number of indicators being reduced from 74 to 55, with all the register indicators being income protected. For the income protection points, payments will be based on the results from 22-23 when those results are finalised. There are 2 new indicators for cholesterol, which are worth 30 points in total, and a new mental health indicator. To fund this, 2 existing indicators have been retired, together with changes to 2 other indicators, mainly relating to the reviews for patients with rheumatoid arthritis and a reduction in the value associated with annual dementia reviews. The QI modules will focus on workforce wellbeing and optimising demand and capacity. So not a massive amount of change to QOF really there for the current year. The main focus on contract changes in this year are 4 main areas, and that is access being the main area, IIF and QOF funding, workforce flexibilities, and also some changes to immunisations and vaccinations. IAF and the additional R's funding Shirley will be covering later on in the session, so I'm not going to touch on that here. So looking at access changes, which is what the key focus appears to be on this year. The most important thing to note about changes to access is there is not any extra funding for this in the contract. So any extra requirements for access, you will not get any extra funding for. So what has changed is that it will be a requirement that patients must be offered an assessment of needs or signposted to an appropriate service at the first point of contact. So you won't be able to ask a patient to contact you again at a later date. What you'll need to do is either offer them an appointment, provide advice and care by an alternative method, direct or invite the patient to make use of appropriate services available to them, or communicate with the patient to request further information. The aim is to provide same-day care to more than 2/5 of patients. It's the intention that online access to records will also be available to all patients no later than the 31st of October 2023, unless the patient has opted out of this. I think originally it was set to be earlier than that, but it's been put back. So 31st of October 23, that will need to be in place. The other change with access is with regards to telephone systems. So from 2025, all analogue ISDN and PSTN lines will be removed, and it will be mandatory that practices use a cloud-based system. A lot of practices have already made this move, particularly over the last few years, with more telephone appointments with the pandemic, but there are still several practices that haven't made this move. What's going to happen is that a better purchasing framework will be developed, which will provide recommended suppliers and apparently a sure value for money. So hopefully that will be the case. When your current telephone contract expires, it will be a requirement that you have a new cloud-based system, and it must be purchased from the framework. Anyone that's looking to move to a new system before 2025, it's been said that you will be given further support, although at the moment there's no further guidance on this. It's not yet been released, so we don't know what that's going to look like. There's also plans to publish later in the spring the GP recovery plan on how access to care will expand further. So it's likely that there will be further demands on practices relating to access as we go throughout the year. Immunisations and vaccinations, then looking at the changes there. Again, not massive changes, but there are some changes. So childhood immunisations, a very small bit of good news on childhood immunisations, but it doesn't have a huge impact financially. You'll recall that when childhood immunisations changed with the introduction of the 6-in-1 vaccinations, there was a target cap introduced. If you didn't hit the 80% target for vaccinations, then you had a clawback of half of what you were paid. Changes have been introduced this year, so that cap has been removed. There have also been changes to the QOF thresholds for childhood immunisations, with the lowering of the lower thresholds and increasing the higher thresholds, as well as putting in some provisions for patients who register too late, so that you're not penalised for that within the childhood immunisations. So it should become easier to achieve those targets in QOF for childhood IMS. HPV then changed to HPV vaccinations. It's currently a 2-dose vaccination. It will be moving to a 1-dose for most patients. For those aged 14 to 25, the 1-dose will apply from the 1st of September to align with school programmes, but it does continue to be paid at £10.06 per vaccination, as do all vaccinations actually, so no uplift in the value per vaccination there this year. Shingles, there's a few changes to shingles vaccinations. From the 1st of September 2023, this will move to a 2-dose system, and the cohort will be expanded to include those aged 60 and over. But to enable that to happen, that will be introduced in stages over a 5-year period. As I said before, all other vaccinations remain unchanged. Other contract changes, general contract changes, GP retention scheme. So until now, there's been a cap for retainers, meaning that they can only work a maximum of 4 sessions in a practice. This cap has been permanently removed. It was removed during COVID. It's now been permanently removed. So a retainer GP can work as many sessions as you'd like them to. However, it's important to note that won't be funded. Any sessions over the 4 sessions, the employing practice will be responsible for the costs on that. But it does mean that they're not restricted to only working the 4 sessions. NHS England are leading a review of GP recruitment and retention, a little too late, you might say. So further changes may arise on this. One other thing that has been introduced as well to try and retain and increase GP sessions is with regards to 24-hour retirement and the fact that you no longer have to restrict how many hours you work after taking 24-hour retirement. So you could go back to working the same hours, whereas before you had to have a month where you were restricted. The final thing on contract changes then is just weight management. We thought that might cease. That has been confirmed that that's continuing for the current year, and the referral fee for that continues at £11.50 per referral. So all in all, not a lot of changes and not a lot of extra money coming to practices with the contract changes.